Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Transcatheter Aortic Valve Replacement. If I have yet to meet you, I'm the patient, the aortic valve patient that started HeartValveSurgery.com all the way back in 2006. The mission of our website is real simple. We want to educate and empower patients just like you. And this webinar, which has had over 800 registrations from patients in countries all over the world, was designed to support that mission. Now, during the webinar, you're going to be in what's known as listen-only mode, but I encourage you to submit your questions throughout the webinar, and I'll explain why as we look at the agenda. First, I'm going to introduce the speakers. Then we're going to have a great discussion about aortic valve disease and treatment options. Then I'd encourage you to put on your seatbelt and grab some popcorn, because we're going to have a very deep and insightful conversation all about TAVR. We're going to answer some questions that you are submitting right now. And then I'm going to ask you to complete a very quick 5-question survey. Now, when it comes to the featured speakers of today, I'd submit to you that we just don't have experts on the webinar with us. We have an absolute dynamic duo. The first member of that dynamic duo is Dr. Howard Herrmann, who's the Director of Cardiac Catheterization Laboratories at Hospital of the University Pennsylvania Health System in Philadelphia, Pennsylvania. He's the Director for Interventional Cardiology. John Winthrop Breyfogle, Professor of Cardiovascular Diseases, Professor of Medicine and Surgery, and Dr. Herrmann has performed not one TAVR, not 10, not 100, but 1,000 TAVR procedures. Dr. Herrmann, thanks so much for being with us today.
Thank you so much, Adam. It's a pleasure to be here. I don't know if I'm the Batman or Robin of this dynamic duo, but I do appreciate the introduction, and I'm looking forward to sharing some of the data that we know about with all of the patients and participants on this webinar.
Thanks so much, Dr. Herrmann. And here are Dr. Herrmann's disclosures. And getting back to that dynamic duo, here he comes, Dr. Robert Lee, who is the co-director of what? You guessed it, Transcatheter Aortic Valve Replacement Program at Penn Presbyterian Medical Center, where in Philadelphia, Pennsylvania. He's the Associate Professor of Clinical Medicine, and he's been nationally recognized as one of America's top doctors. Dr. Lee has performed over 1,700 TAVR procedures. Dr. Lee, thanks so much for being with us today.
Really great to be here, Adam.
So I could go on about all the accolades of Dr. Herrmann and Dr. Lee and the Penn Medicine team. And what I want to do is show you this. These are coming onto your screen right now, the smiling faces and names of patients from the HeartValveSurgery.com community who went to Penn Medicine and had successful, very successful procedures, whether it's Stephen, Mark, Michael, Sean, Diane, Maury. That said, I am honored and humbled that you are taking time away from your very busy practices at Penn Medicine to help educate our community. Now, to kick off the webinar, I'm going to turn it over to Dr. Robert Lee with a very important question for everybody on the line, which is, what is the aortic valve?
Great, thanks a lot, Adam. So for my part of the talk, what I was hoping to do was to provide kind of a brief primer on aortic valve disease and aortic stenosis. And when Dr. Herrmann does his part of the talk, he'll kind of do more of a deep dive into TAVR, the nuances of TAVR, and some of the thought processes that go into the decision making. So what is the aortic valve? So the aortic valve is one of 4 heart valves. And the heart valves basically function as one-way valves to control the flow of blood both into and out of the main pumping chambers. So the aortic valve is the outflow valve for the left ventricle. And essentially, every single time the heart beats, in order to push the blood out to the body, all of the blood has to go through the aortic valve. So the aortic valve opens up to let the blood out. And then in between heartbeats, the valve closes in order to keep the blood from going back into the main pumping chamber. On the right-hand side of the screen are pictures of what an aortic valve looks like. On the top part, you can see the aortic valve both in a closed position as well as an open position. And you can see on the bottom image kind of a moving live aortic valve. So that's what an aortic valve looks like as it's opening and closing. Some of the things I want to point out, first of all, you can see that the aortic valve has 3 flaps or cusps that open and close with every heartbeat. And you can also see that the structure of the leaflets or the cusps are that the tissue is actually very thin and flexible. Next slide, please. So what is aortic stenosis? Aortic stenosis occurs when those thin, flexible leaflets of the aortic valve become progressively thickened and then calcified. And this process of thickening and calcification results in the leaflets not being able to move well. And this results functionally in a restriction in the blood flow out of the heart because the valve leaflets no longer open. The condition is actually pretty common. Heart valve disease in general is actually quite common and happens in about 2.5% of the general population in America. And it actually happens even more frequently as people get older, so that 13% of people over age 80 have valvular heart disease. And out of all the different types of valvular heart disease, aortic stenosis is the most common. It usually affects older people as they get older. And unfortunately, when it reaches its later stages, the prognosis with aortic stenosis is quite poor. Next slide, please. So what causes aortic stenosis? I just want to spend a couple minutes talking briefly about this. This is a condition that where there are different forms, so there are different mechanisms that cause the blockage to become blocked. In the United States, the most common form is what we refer to as calcific or degenerative aortic stenosis. And this is something where it's not completely understood why this process starts. But what happens is inflammation begins in the leaflets or the flaps of the valve. And over time, the inflammation leads to fibrosis or scarring, and then subsequently calcification. And the calcification and the scarring lead to restriction in the flexibility of the leaflets. Next slide, please. Another very common cause of aortic stenosis is related to something that we refer to as a bicuspid aortic valve. So the typical aortic valve, as we saw in the previous slide, has 3 flaps that open and close. And in about 2% of the US population, people are actually born, so this is a congenital condition, people are actually born with an aortic valve that instead of having 3 flaps, only has 2 flaps, either 2 symmetric appearing flaps, as you can see on the top right image, or right underneath that is another type of bicuspid aortic valve where it kind of almost looks like a 3-leaflet valve, but actually 2 of those leaflets are kind of fused together, so it becomes functionally a valve that has only 2 flaps. Next slide. And actually, can you go back up one? I just realized something. So with bicuspid aortic valve, one of the things that happens is that the blood flow through the valve leaflets is a little bit abnormal. When people are young, the valve functions okay. It's not really blocked and doesn't really leak in most patients. But as people get older, because of the abnormal blood flow, this results in premature wear and tear and development of aortic stenosis down the road. Next slide. And then a cause of aortic stenosis that used to be quite common, but is now less common now with antibiotics being used widely for treatment of bacterial infections, is a condition called rheumatic fever. And what happens with rheumatic fever is that it's actually an inflammatory autoimmune condition that results as a consequence of infection with a bacteria called group A strep. So strep throat is actually a very common clinical condition that occurs with group A strep. And for some people, after they develop strep throat, in particular, if they haven't been treated with antibiotics, a few weeks down the road, they develop this condition where the body starts attacking its own tissues, including the brain, joints and skin, but also the heart. And if the valve tissue is involved in this process, the valve leaflets can become scarred, calcified, and blocked. So aortic stenosis is actually a condition where the progression of the problem is actually quite slow. It can actually take many years, sometimes even decades, to go from the earliest stages of aortic stenosis to the later stages of the problem. And it's really only people who have later stage aortic stenosis who develop symptoms. The most common symptom is actually shortness of breath, and in particular with exertion. There's kind of a related symptom that we refer to as exertional fatigue, exertional intolerance. And this is a situation where a person doesn't frankly feel short of breath, but they feel like when they're trying to do something, they just don't have the power or the energy that they feel like they should. A lot of patients will develop chest pains when they have significant aortic stenosis. And because of the poor outflow of blood from the heart because of the blocked valve, some people will become lightheaded. And if this is bad enough, they actually can frankly pass out. And if patients have heart failure as a consequence of aortic stenosis, they can frequently develop leg swelling as well. Next slide, please. So how do we treat aortic stenosis, or when do we treat it is actually the really key question. Aortic stenosis, as I said before, is a condition that can take a long time to develop. So we actually have many, many patients who have aortic stenosis where we're just monitoring them because we don't feel like it's time to provide treatment yet. And these are patients who are in earlier stages of the process. And so what we frequently do is we'll monitor them by following their clinical symptoms and also doing periodic echocardiograms to measure the degree of aortic stenosis. And when aortic stenosis becomes severe, that's when we become most concerned. And in particular, if aortic stenosis is severe and it's associated with symptoms or any evidence of weakening of the heart muscle because of the extra strain pushing against this blocked valve, those are clear indications to go ahead and provide treatment for aortic stenosis. There are also some other situations where we'll recommend treatment, including patients who might be undergoing heart surgery for other reasons, people who have had a stress test, or the stress test is abnormal, we believe, because of the aortic stenosis. Some patients will have relatively rapid progression of the severity of aortic stenosis, and that's a situation that is riskier than the usual slower progression. And then occasionally we'll have a patient where we'll discover their aortic stenosis, and the severity of the stenosis in the valve is extreme. So if the numbers that we're reporting where the severity of the aortic stenosis is on really the kind of the upper range of possibility, that's a situation that's risky, and we believe that treatment is often recommended in that kind of situation. And then finally, if there's really any evidence that the heart might be starting to feel the strain of the blocked heart valve, we'll recommend treatment. And the situation that sometimes arises is that we'll do a blood test, it's called a BNP, that is abnormal, and that indicates to us that the situation is worse than we might otherwise think. Next slide, please. So what are the general treatment options for aortic stenosis? Although sometimes we'll prescribe medications when people have aortic stenosis, unfortunately, there's no medical medication treatment that has yet been found that will fix the underlying problem. So the underlying problem with aortic stenosis is the valve does not open well. There's no medication that will restore flexibility to the leaflets. And there hasn't been found any medications that will even slow or stop the progression either. So really, there's no medication to provide fundamental treatment here. We do prescribe diuretics frequently for symptoms, but diuretics don't change the underlying problem. In the 1980s, a procedure called balloon aortic valvuloplasty was developed. And it's basically a procedure where we inflate a very large balloon inside of the aortic valve in order to kind of try to crack open those calcific deposits on the valve. Unfortunately, the treatment did not prove to be very effective, and whatever benefit was conferred was short lasting. So as a primary treatment for aortic stenosis, balloon aortic valvuloplasty really is not done. So really the only effective treatment for aortic stenosis when we believe that treatment is necessary is to somehow find a way to put a new heart valve in. Traditionally, that's done with open surgical aortic valve replacement. And then a newer treatment, which is really the focus of today, is a minimally invasive procedure called transcatheter aortic valve replacement. Okay, next slide, please. So I just wanted to review those two treatments a little bit. So first, surgical aortic valve replacement. As the name suggests, this is open heart surgery. It's what most people think of when they think of a big heart operation. It requires a chest incision. General anesthesia is always used, as well as mechanical ventilation, so the breathing tube. And a heart-lung machine is also required. And a heart-lung machine basically takes over the work of the heart by circulating the blood outside the body while the heart is being worked on. The incision that is made with this operation varies. So the traditional operation is what we refer to as a median sternotomy, where the sternum or the breastbone is opened from the very top to the very bottom, and the chest is fully exposed or fully open. Smaller incisions, however, are very frequently done nowadays, and these are sort of minimally invasive approaches to do the same operation with a much smaller incision. The hospitalization after this kind of operation is usually between 5 and 7 days. The initial recovery at home usually takes about 4 to 6 weeks, and it's usually 2 to 3 months before patients are kind of really back to sort of quote unquote normal. Next slide, please. One of the advantages of open heart surgery is that there are really a large variety of valves that can be implanted using the surgical technique. And artificial heart valves really fall under two general categories. One are a class of valves called bioprosthetic valves, where essentially the flaps are always made out of some kind of biological material. And the alternative general category of valves are what we refer to as mechanical valves. And with mechanical valves, all the parts of the valve are made out of durable materials such as carbon, metal, plastics, and fabric. Really, the main advantage of mechanical valves is that the durability is extremely high. So when we implant a mechanical valve, we expect that it's going to last a very, very long time. The main disadvantage of mechanical valves is that they always require blood thinning with warfarin. And a lot of patients don't want to take Coumadin warfarin. Bioprosthetic valves, on the other hand, don't require Coumadin, but the main disadvantage of bioprosthetic valves is that because the flaps are made out of biological material, eventually that material will break down and wear out. So the valve can become either blocked again because the leaflets become stiff, or they break down and start leaking. Next slide, please. Another kind of open surgical aortic valve replacement isn't done nearly as much as traditional valve replacement, but this is called the Ross procedure. And I'm bringing it up because it's becoming increasingly popular. It's what we refer to as a pulmonary autograft. And what the surgeon does with this kind of operation is they take the pulmonic valve, which is structurally very similar to the aortic valve, and they take the patient's pulmonic valve and they remove it from its original spot. And they use that to replace the damaged or diseased aortic valve. In the place of the original pulmonic valve, they place an artificial heart valve that we refer to as a pulmonary homograft, which is essentially a pulmonic valve from a deceased person. And so basically you have valves in kind of two new positions. It's a technically very complicated operation to perform. And really only certain specialized centers are able to do this operation. Penn is one of them. We have several surgeons who are very interested in the Ross procedure and do it quite well. It's something that's typically reserved for younger patients because it's a difficult operation to do. Next slide, please. And then finally, there's transcatheter aortic valve replacement, which is essentially a catheter-based technique for implanting a new heart valve. And because we're delivering a valve using a catheter, it's much less invasive. It avoids open heart surgery. The procedure is, in most centers, typically done with sedation as opposed to general anesthesia, so there's no ventilator involved. Certainly a heart-lung machine is not required because the heart is never truly stopped. And hospitalization is quite short, typically 1 to 3 days. And for the vast majority of patients, it's really only 1 or 2 days. And likewise, the recovery is very quick. Because the TAVR procedure doesn't involve much damage to any of the tissues because there's no incision, there really is not a lot of healing that occurs or that needs to occur. So patients are up and around pretty quickly, and they're pretty much back to what they were doing before within a week or two. Next slide, please. So the next 3 slides, I'm just going to briefly show the 3 main TAVR systems that are available in the United States. The first one is the Edwards SAPIEN 3 Ultra valve. This is the current version of a series of sort of progressive improvements in this valve over the last 10 to 15 years. And the structure of the valve is that the flaps of the valve are made out of a material called bovine pericardium. So the leaflets are created out of the pericardial sac of cows. The leaflets are sewn onto kind of a lattice metal frame that's made out of cobalt chromium. And you can see, because it's sort of a lattice work, that's what allows the valve to be folded into a much smaller profile. And the picture in the middle is an example of a sapien valve that's been folded and collapsed onto the delivery system. The delivery system is that blue part. And the size of the system is quite small. It's 14 to 16 French, which is the equivalent of about 5 millimeters in diameter. And that's why we're able to insert it into an artery and pass it on to the heart, because it is so small. Next slide, please. Another type of TAVR valve that's used quite frequently is called the Medtronic Evolute valve. The current version is the FX, which, like the sapien valve, the Medtronic valve has gone through several iterations over the years. It used to be called a core valve. So if you see that name out there, the valve is no longer branded as core valve, but people still frequently refer to it as that. And the structure of this valve is similar, but a little bit different to the sapien valve. The leaflets, or the flaps of the valve, are made out of a material called porcine pericardium, so basically tissue from the pig's heart. But the frame is made out of a metal called nitinol, or nickel titanium. And nickel titanium is an interesting metal because when you create a frame, a valve frame out of it, you can actually compress it into a very small profile. But when you release it, it kind of pops back into its previous shape. So it's what we refer to as a self-expanding valve. Next slide. And the third valve is the Abbott Portico valve. And actually, the latest version of this valve was just FDA approved a couple of weeks ago. It's called a Navitor. So you might hear that in the app there as well. And like the first two valves, the general design is pretty similar. There's kind of a metal frame. This one is made out of nitinol, and then leaflets that are made out of pericardial material. And for the Portico valve, or the Navitor valve, the leaflets are made out of bovine pericardium. Next slide, please. So this is just it's actually very well-known animation and words for the steps on how the TAVR procedure is done with the sapien valve. The first step is we take a very thin, tiny wire that we refer to as a guide wire, and we position that across the valve. And we use this wire as basically a rail to kind of pass all of our equipment to the heart. Sometimes we'll do a valvuloplasty to prepare the stenotic valve for the implant. And then when we're actually delivering the new valve, the first step is we place what's referred to as a sheath, which is kind of provides a doorway into the artery to allow our equipment to get into the body safely. And that's the delivery system with the crimped valve. That's the silver part at the end of it that's being passed up and positioned within the valve. And then as we expand the valve, it presses up against the leaflets of the damaged valve and basically starts working as soon as it's opened up. So it's a very quick process of delivering the valve. Next slide, please. So we talked about surgical aortic valve replacement, and we talked about transcatheter aortic valve replacement. And although there's a lot of excitement and a lot of press with TAVR, surgical aortic valve replacement is actually still done very frequently. It's really a tremendously effective operation. The surgeons have been doing it for decades, and they've become really exceptionally good at it. The results for patients undergoing surgical aortic valve replacement are really quite extraordinary. So how do we decide what's the best choice for any individual patient? There's actually a pretty complicated process that we engage when we're evaluating somebody for aortic valve treatment. At Penn and in many centers, is done with what we refer to as a heart valve team. And this team involves a whole lot of different types of doctors: cardiac surgeons, cardiologists, interventional cardiologists, frequently anesthesiologists, anybody who would have who could potentially have useful input into a patient's care are engaged, and we make a decision or we make a recommendation. The patient is a big part of this process as well. So we do what we refer to as shared decision, where we talk to the patient in a lot of detail about what the options are. We try to get a sense of what's important to the patient. Everybody has different feelings about what they want to be done with their body, and we try to get a feeling for what would be most appropriate for them. And then ultimately, we come to a shared decision about the best way forward. A person's age is actually weighs heavily on our minds, because somebody who's 50 with aortic stenosis is very different from somebody who's 90 with aortic stenosis, as everybody might imagine. So somebody who's 50, and in particular, if they want a prosthetic valve because they're not interested in taking warfarin, because the durability of a prosthetic valve is usually somewhere in the 10 to 15-year range, you're basically telling this person that you're going to do a procedure where the likelihood is extremely high that they will live long enough to see that valve wear out. And so when that valve wears out, you have to make a decision about what is going to be the next step. And we try to be proactive with this thought process so that we have an idea of how we're going to manage the issue during the entire course of their lives. Somebody who's 50, their valve is going to wear out if you put it by prosthesis. Somebody who's 90, the likelihood that the valve will wear out is very low. So we look at all the details of their medical history, medical conditions, primarily to get a sense for what the risk of surgery may be for them. And then we look very closely at the anatomy of the valve, because for TAVR in particular, there are a number of anatomic constraints that we have to be aware of before deciding to proceed with TAVR. Next slide, please. So, as an example, for surgical aortic valve replacement, there are certain situations that where we lean more towards recommending surgery. So, somebody who's younger, somebody who has bicuspid aortic valve. Most of the robust data for the effectiveness of TAVR was obtained for patients who have the traditional 3-leaflet valve. So there's much less information known about how effective TAVR is for bicuspid aortic valve. But we still do it fairly frequently, but sort of the evidence base isn't as strong for bicuspid valve and TAVR. And patients who have anatomy that isn't very good for TAVR, we obviously lean more towards surgery. And if they have other cardiac conditions that may require surgical repair, then those are situations where we're more often going to recommend surgery. On the other hand, TAVR is a technique that is strongly favored if we feel that open surgery is risky. So people who are older, and in particular, people who have medical conditions that we believe significantly increase the risk of doing a traditional operation, those are very good candidates for TAVR. And there's actually a very, very large group of people who are in the middle. So people that we review and we evaluate them, and we believe, yes, surgery would be very reasonable here. And yes, TAVR would also be very reasonable here. And obviously, in this very large group of patients, it's up to them in many respects. So that's what I was referring to with the shared decision process.
So that was a great summary, Rob. And I think everybody understands now the disease and some of the options for treating it. And what I'm going to try to cover in my 15 or 20 minutes are get a little more deep into the weeds of the procedure, some of the complications, and some of the issues that I've been seeing in the questions and answers, because I think I'll have answers to some of those questions in the course of my slides. So I just wanted to start with this one to remind you that we think of TAVR as a form of structural heart disease, and we have a lot of different options now that we didn't have 30 years ago. When I started doing interventional cardiology, really the only thing we could do was angioplasty and then stents. But now we really treat a variety of conditions within the heart, including all 4 of the valves, although only TAVR is currently an approved procedure. Next slide, please. So I'm going to try to take you a little bit through the past, a little bit of the present, and then where I think things are going in the future. TAVR really began back in 2002 in France with a revolutionary attempt to treat this disease by Alain Cribier. And it was brought to the US around 2005 or 6, and we performed the first one at Penn in 2007. And I was here and started the program with Dr. Bavaria at that time. And I will like to also point out that this is a procedure we do with our cardiac surgical colleagues. Dr. Lee and I are interventional cardiologists, but it is a team procedure. We do this as a heart team with heart surgeons, and they are an integral part of both the evaluation of patients as well as their treatment. And I'll have more to say about that later on. Next slide, please. Somebody asked in the questions about risk, how do you decide who's a high-risk patient? Well, these are some of the criteria that are used, and we start with what's the risk of surgery, and that's what's in that first line, the SDS predicted risk of mortality at 30 days. And we divide patients into a risk of less than 3 or 4%, 4 to 8%, and then high risk is more than 8%. But we add to that other factors, how frail the patient is, whether they have other comorbidities, and how good a candidate they are for either surgery or TAVR. And all of that goes into deciding the risk. Next slide. And when we started, we did think of TAVR as only for inoperable or high-risk patients. But through a series of very carefully done trials, what we found is that TAVR is at least as good as surgery, and in some cases better, for all risk categories. And so we think of this now a little less about the risk of the patient and more about their longevity and what procedure they want and what we're going to do if that valve wears out. And so as Rob alluded to, we do have to think about the lifetime management of younger patients, less so for the 85 or 90-year-old. And we'll talk a little bit more about that in the next slide. So this is just one of the big trials, or two of the big trials, one with each valve, that demonstrated that even in low-risk patients, and that's what you see there in the lower bars in the top and the bottom with the two different valves, the rates of rehospitalization, stroke, and mortality in the short run, 1 year, are better with TAVR even in low-risk patients. But we do have to think about what we're going to do when these valves wear out, because all bioprosthetic valves wear out after some period of time. And whether that's 10 years, 15 years, or 20 years varies by the valve and the patient. But if you're 50, that is a consideration we have to think about, less so when you're over 80. Next slide, please. And so that's where the heart team comes into account. And that's why it's important that we have not just one doctor making these decisions for you, but have a team approach. And our team includes the anesthesiologist, the imagers, the cardiac surgeon, and the interventional cardiologist who are going to do the procedure. And Rob and I and everybody at Penn meets once a week to go over all the patients and decide that, is it the right choice? Should they get a TAVR? Should they get surgery? And what are we going to do the next time? And that's kind of what you see at the bottom there. The older patients, it favors TAVR. The younger patients, we think a little bit more about surgery as the first option. Next slide, please. And this sort of also points out that it's not just age and surgical risk, but it also depends on the morphology of the valve, other medical problems. If you need to have bypass surgery at the same time, then TAVR may not be the best option for you. If you have a leaky mitral valve and you're a young patient who can have an operation that's more complicated, maybe surgery with treatment of both valves is a better option than just treating one of the valves. But if you're 90, maybe treating the aortic valve is a good option for improving quality of life and maybe less risky than open heart surgery. Next slide. And this is just a snapshot of where we are in the US at this point. And I won't belabor this because I want to get to your questions, but this procedure, which began around 2007, got approved around 2011, has now expanded rapidly around the world. There are over 800 sites that do TAVR in the US. The mortality of the procedure has fallen to about 1%. We're doing them all now through the groin. Hardly ever do we have to use alternative access. And we're treating all risk categories, about a third low risk, a third intermediate risk, and a third high risk. Next slide, please. So what are some of the future problems? And this is where we talk a little bit about complications like stroke and leaflet thrombosis, some of the issues with who else is going to get this procedure, disease expansion, and we'll touch on bicuspid valves. I saw a lot of questions about that. And then finally, hit the next button, technical hurdles. What are some of the complications that we have to deal with? So let's go to the next slide and talk a little bit about these. So stroke has been one of the major concerns everybody has. I know that some patients are more worried about stroke than dying, and we are worried about it as well. And it is part and parcel of this procedure. So if you look at the in-hospital stroke rates, which are in blue, it's still between 1 and 2%. And if you hit the next slide again, you'll see that even after we got what are called cerebral protection devices, and somebody asked about that in the questions, these are devices that help catch some of the debris from the valve as they go into that potentially could go to the brain. We haven't made a big impact on stroke. Now, that's not that different than the stroke rates in surgery. So I don't mean to tell you that you shouldn't have a TAVR because you're afraid of stroke, but we haven't been able to lower that rate as much as we would like. And if you go to the next slide, this shows you what some of those devices look like. These are the filters that we sometimes put into the brain vessels to try to capture debris and lower the rate of stroke. And the trials have been not perfect to show that they work. They seem to have a slight benefit, which is what you see there in total stroke. And in one study, they seem to reduce disabling stroke better, but not every trial has been that positive. And so some hospitals use these devices, which are expensive and add time to the procedure. And other hospitals have made the decision that the results aren't good enough to recommend using them in all patients. At Penn, we do use these in the majority of our patients based on our feeling that they probably help. But I can't fault people who don't use them because the data is just not that clear. As you keep hitting the slide, you'll see there are more devices coming along, different ones, different types of capture devices. And one more time, you'll see that there are a lot of these coming along, and we're going to be in trials of several of these. So as an investigative approach, this is an area of intense interest around the country and at Penn, and we are going to be utilizing some of these devices to try to reduce that stroke rate from the 1 or 2% to an even lower number. Next slide, please. Another complication that occurs is that you can get clot or thrombus thickening occurring on these leaflets. It happens with surgical valves as well, but seems to happen a little more often with the TAVR valves. And it's a complicated problem. It comes and goes. It may have something to do with valve design and shape after deployment. It doesn't correlate that much with adverse clinical outcomes, and it can be prevented with blood thinners. So we do watch for this. We get echoes. That's one of the reasons patients will get an echo at 30 days after their TAVR procedure. Sometimes we follow that up with a CT scan. And if we see it in our hospital, we do tend to treat it with a period of time, blood thinning, 6 months, something like that. And it does seem to get better. But it is something that you should be aware of. But it's still one of those sort of new diseases that came up ever since TAVR. Next slide, please. Another issue that we're very concerned about, both at Penn and nationally, is the fact that although there are 800 sites performing TAVR, many of the disadvantaged among our society do not seem to have the same access to TAVR that they should, and that we are not treating as many of the economically disadvantaged populations, African Americans, as well as we should be. And so that is an area of interest of how do we expand these new technologies to everyone and make sure that we offer it to anyone who is eligible for it. And the next slide shows some of the things that are being done to improve these disparities to care. And I'm happy to talk about this a little bit at the end if people have questions about it. But the point is everybody should have access, and there are enough centers around that we should be able to get almost anybody to a TAVR site. Next slide, please. There were a lot of questions about bicuspid valves. Rob mentioned that this is a common problem, about 2%. These patients were excluded from most of the clinical trials. So the evidence base that we have for TAVR in bicuspid valves is much smaller. a few small, couple hundred patient series and some registry data. And what we know about bicuspid valves is because they're a little bit oval and these valves are circular, they may not seal quite as well as the edges. So there are more leaks at the edges. There are more patients who need permanent pacemakers. And maybe it doesn't work quite as well as surgery, although it's certainly a safer procedure for a high-risk patient. And so there is some controversy in the young bicuspid aortic valve patient as to whether they should have surgery up front and reserve TAVR for when that surgical valve wears out. That's our general approach for patients under, say, 65 years of age, or whether if they're older, they can get a TAVR and we can still do another TAVR in that TAVR valve if it fails, but they might be subjected for the first 10 or 15 years with that TAVR valve to a slightly greater risk of a leak. And there are different types of bicuspid valves as shown on the right side, and measuring them is an art in and of itself. So the point is, if you have a bicuspid valve, you're not excluded from TAVR, but it is an important shared decision that you have to make with your physician about based on your age, the kind of bicuspid valve you have, and what we're going to do when that first valve wears out. So it's a complex decision for bicuspid aortic valve patients, particularly the younger ones. And I encourage you to have that conversation with your physicians and with surgeons who understand how to treat these patients, these kinds of valves in the best possible way. Next slide. We also know that permanent pacemakers happen in about 5 to 10% of patients after TAVR. And that has to do with the fact that the wiring of the heart, the connections between the upper and lower chambers, run very close to the aortic valve. And when we inflate the balloon or we inflate the valve in that area, we put pressure on those wiring and we can disrupt them. It also happens with surgery, but it seems to happen just a little bit more often with the TAVR patients. And so you have to be aware of that. And we are aware of it during the procedure. We use a temporary pacemaker during the procedure. And that's one of the reasons you're in the hospital afterwards, to watch for that and make sure that you don't need one. Now, hit the next button. That just sort of shows the anatomy again. And there are some techniques that we're utilizing, and everyone is, to try to lower that risk. And these are technical aspects of the procedure to try to reduce that risk from 10% down, as you see there in some studies, to 6 or 7%. Next slide. There's also an issue with the size of the valve, and we know that if you get too small a valve, that can be a bit of an obstruction. We're trading aortic stenosis, which is an obstruction to outflow from the heart, for a valve. But if you get too small a valve for your body, it may also still obstruct a bit. And so it's important to get the largest possible valve you can. And that can be done sometimes better with surgery than it is with TAVR, and sometimes with different TAVR valves. And so those are complex decisions that we're still wrestling with and trying to understand. And we actually are part of a international trial that is examining that issue in women who tend to have the smallest aortic annuli and the ones that are most at risk for this problem that's termed prosthesis-patient mismatch. Next. And this is just a copy of the design of the trial. I have the privilege of leading this trial that's funded by one of the TAVR manufacturers. Next slide, please. And so as we think about all these things, one of the most important things is durability. How long are you going to be able to live with this valve, and what are we going to do when it wears out? And so those are decisions that we're thinking about more and more now, especially as we move into lower risk and younger patients. We can do TAVRs inside TAVR valves. We can do TAVRs inside surgical valves. Rarely would we ever have to do a third valve, but it's theoretically possible. Most of the time, we're talking about 2 valves. And so we're starting to think about that more in the younger patients. Which kind of valve is best for the next one? Is it a surgical valve? Is it one type of TAVR valve? Where are we placing it to make sure that the risks of the second TAVR valve 15 years later will be able to not cause a problem for, say, coronary obstruction that we might have to worry about in some situations of putting 2 valves in together. Next. And this just sort of goes over some of that, and you'll be able, I'm not going to go through all the details on this slide. I think I covered most of the points. Next slide. And finally, we have to worry about structural valve deterioration. How long are these valves going to last? In some studies, and this one is an example of that, the TAVR valves actually did better than the surgical valves at 5 years. And whether that's going to continue to be the trend, whether it's true of all valves, we don't really know. We think that these TAVR valves, we have good data out to about 8 or 9 years now showing that they're pretty robust. But if, say, a surgical valve lasts on average 15 years, is it possible that a TAVR valve lasts on average only 12 or 13 years? We wouldn't know that yet. And it's a fast-changing field. The valves keep getting better. But that's kind of the ballpark of what we're thinking about, 10 to 15 years for either one. And we have to think about that, what we're going to use for the second valve if you're a younger person. Next slide. The other couple of points I want to make is that aortic stenosis is a gradual disease. It doesn't just creep up on you and one day you have severe aortic stenosis and before that you had no aortic stenosis. There is mild and moderate aortic stenosis, and they have some risk as well. And as the valve gradually narrows, the heart has to thicken to take care of that and work harder. And there is a risk of dying even as you get toward severe aortic stenosis. And so there has been a trend to start thinking about fixing some of these valves a little earlier, even before you have severe aortic stenosis. That is not the current paradigm that we all operate under, but there are trials going on now that are starting to think about backing that up a little bit. Maybe we should treat people before they're symptomatic who have severe aortic stenosis. Maybe some patients who have moderate aortic stenosis with symptoms should be treated even though they don't have severe aortic stenosis. And so that's the way the future is thinking, going a little bit earlier in the disease progression. Next slide, please.
Dr. Herrmann, can I interject real quick? I'm sure patients are wondering right now, talking about taking care of the aortic stenosis earlier. You mentioned some clinical trials. Can you share by name what those may be? Because patients may want to do some research on those.
Yeah, there are several from each of the manufacturers. At Penn, we're part of the Expand TAVR trial, which is a Medtronic trial that's looking at moderate aortic stenosis. There have been trials with the Edwards valve, one called TAVR Unload, which is treating patients who have muscle dysfunction and less than severe aortic stenosis to see if that can help their heart muscle recover better. And there is an Edwards trial also in asymptomatic but severe aortic stenosis called Early TAVR.
Thank you.
Next slide. And this is just an example of showing that progression, how the heart muscle thickens over time, gradually gets fibrotic. And one of the things that's very exciting and I think will be part of the future of treatment of aortic stenosis is medications that might retard the progression of this disease. If you find out you have mild or moderate AS, as you see in the next slide, it's a very complicated paradigm of what causes aortic stenosis. And I won't make you go through the details of this slide, but the concept is there's a lot going on as this valve gets thick and calcifies, and there may be places where we can interrupt that pathway. One of the ones that you may have heard of is called lipoprotein A, which is a form of the lipid pathway, and there are some medications that we already have that can interrupt that pathway. They're not yet being used for aortic stenosis, but there are going to be some trials that look at that in the future. Next slide. And so I'll end here with this slide, which is just a little bit of a plug for our program here at Penn, where we do about 600 cases annually. We are, as you see to the right there, one of the top rated programs with a 3-star rating in the US, which is not given to every program, but is based on our outcomes. And we still do the procedure in a very team-oriented approach. I mentioned that every procedure is done with a cardiac surgeon and an interventional cardiologist. Dr. Bavaria, Dr. Zito, who you see pictured there with me on the front page of the New York Times a few years ago, Dr. Desai, Dr. Atluri, Dr. Ibrahim are all surgeons at Penn who do these procedures with us. And it is a team approach. We also use anesthesia on every procedure, cardiac anesthesia, to make it comfortable for patients, even though they're not put underneath general anesthesia, they're sedated well. And most of our patients go home in the first 1 or 2 days after the procedure, which is typical nationally. So I'll end there and see if we have some time for some questions, because I think there are still quite a few coming in.
Let's get right to Hossein ask, is TAVR 100% safe? Crashing a valve over an old valve seems to be mysterious. What happens to the old valve if during TAVR the old valve gets fragmented? Can it cause a blockage or stroke?
You know, that's a really good question, and it's a question that we very, very frequently hear. And as really any medical procedure or really any medical treatment has, there's always going to be some risk of a problem. I think Dr. Herrmann alluded to a lot of the potential issues. Thankfully, the likelihood of a significant complication with TAVR is quite low these days. It's gotten progressively lower in terms of the complication rate from the beginning of the procedure. But you have to kind of weigh the consequences or weigh the balance between the risk, which is very low, that's associated with TAVR, but also the risks of not doing anything.
Right. I think that's the key point. You're not balancing the TAVR procedure against doing nothing. You're balancing it against doing nothing and suffering the consequences of doing nothing, which are much higher than the risks of the TAVR procedure.
Great. Let's go on to the next one. We talked about bicuspid aortic valve, so I think we're going to pass on this one. Thank you for that, Dr. Herrmann. And I got several of these questions from folks like John and Barry who asked, can you have a TAVR after 10 years with a minimally invasive PIG valve replacement?
Yes, we call that valve in valve or TAVR in SAVR. We can put TAVR valves inside surgical valves, and that is an approved procedure, not only for the aortic valve, but also we do it not infrequently in the mitral and tricuspid surgical valves as well, and the pulmonic valve. So if you have a previous surgical valve in any of your 4 valves and it starts to degenerate, we can often put a TAVR prosthesis inside it. That isn't without, though, it's not everybody, it's the majority of people. And we do have to do some careful analyses to make sure we're not going to obstruct the coronary arteries and that the size of the different valves works for that. But in general, the answer is yes.
I've got to tell you, as you both have alluded to the lifetime management of valve disease, I did not know that. I did not know that TAVRs were being implanted in mitral and other valves. That's very interesting. Moving on to the next question. We get this a lot because a lot of patients with bicuspid valves have aortic aneurysms. And Lloyd asks, at 72 years of age, I previously had 2 valve replacements and an aortic graft. Can TAVR be done if the graft is okay and I need another valve?
Typically, this is technically possible. So we frequently will do what's referred to as a valve-in-valve procedure, where we can implant a TAVR valve within a previous surgical bioprosthesis. The existence or the presence of an aortic graft can sometimes make the valve delivery more complicated, but it's just about always possible. So the short answer is yes, it potentially could be done.
It also brings up another point for patients who, I know there are a lot of questions about bicuspid aortic valves, and we seem to have a lot of patients on the call who have that. And we should point out that bicuspid valves are also associated with some disease of the ascending aorta. And that's why you often get that graft that you see there. And if you're a young patient and you have an enlarged aorta along with a severely stenotic or leaking bicuspid valve, then surgery is likely the best option for you because you can treat both conditions. And what you don't want to do is have a TAVR for your bicuspid valve and then have a problem with your aorta a few years later. Now, if you're older and that aorta doesn't look so bad, then that still may be the best option to have a TAVR, but it's a more complicated disease than just the valve if you have bicuspid disease.
Great. Thank you so much for those insights. And with that being said, we are just at the end of the hour. And before we wrap this up, I want to for everybody in the line, please don't hang up. I want to thank you for coming together today. Obviously, with all the questions, all the registrations, and over 300 people online, this was important to you. And as you know, it's important to me. So thank you on behalf of everybody for trying to live the best, healthiest lives that we can. I want to thank Dr. Herrmann and Dr. Lee, the dynamic duo of TAVR. Thank you so much for your time today and your excellent presentations. They are very helpful. And as we wind up this webinar, I want to thank you for a very quick survey that's coming on your screen right now. And as we conclude this, thank you again, Dr. Herrmann, and thank you, Dr. Lee.
Pleasure to be here.
Thanks very much for the opportunity, Adam.